Hello and welcome to Health Watch, a collaboration between Reuters and the Forum at the Harvard School of Public Health. I'm your host, David Morgan, healthcare correspondent for Reuters in Washington. And with me today is Professor Barry Bloom of the Harvard School of Public Health. Professor Bloom is a leading expert in infectious diseases, including Ebola, and a former Dean of Public Health at Harvard. Hello, Professor. Welcome to Health Watch.
Hello to you.
As we know, the Ebola outbreak is traveling very quickly.
I consider this a top national security priority.
While we are making progress, we are not where we can say that we need to be.
It has currently, according to official estimates, infected nearly 7,500 people in West Africa. That's up from 4,000 a month ago, and expectations are that it could reach 20,000 cases early next month, according to the World Health Organization. In the meantime, the outbreak has traveled beyond the West Africa region. The first U.S. diagnosed case of Ebola, a Liberian man, has died in a Dallas hospital.
On behalf of the city of Dallas, I extend our deepest sympathies to the families and the friends of Mr. Duncan.
So my first question for you, Professor, has to do with the U.S. response on U.S. soil. Over the past several years, the public health system in the United States has sustained cuts in financing and cuts in staff. Is it possible that those cutbacks have affected the ability of U.S. health authorities to detect and trace and contain Ebola?
The cuts in public health in the United States have been hurtful in many ways that affect cities and towns in their routine activities. But the world of public health in the United States changed after 9/11 and the anthrax outbreaks, followed by SARS and influenza pandemics. There has been an enormous amount of preparation for the emergence of infectious diseases that we may or may not have ever seen. And I would say to a large extent, even with the cuts, the public health system is prepared. Certainly here in Boston, all the major hospitals have been rehearsing for an event. So in principle, we should be able in any major city in this country, particularly ones that receive airplanes, to be prepared to handle anybody that has Ebola.
Is there an Ebola preparedness plan at the national level, or is it more a question of health authorities taking the preparedness plan for things like pandemic flu and adapting it to Ebola?
The pandemic flu plan was a national plan, huge amounts of input from hospitals and doctors and public health people from all over the country. But in fact, there are guidances that have been issued since August by the Centers for Disease Control on every imaginable aspect, from how ambulances are to handle suspected patients, to disposal of waste and diagnosis of Ebola and discriminating a case description of Ebola versus influenza and other things. So these guidances have been sent out multiple times to all the hospitals. The state departments and the City of Boston Health Department have sent notices to physicians of what to look for and what to be on the alert for. In that sense, we have a functional plan.
Is that enough, however? In Dallas, for example, Ebola patient was sent home when he first came to the hospital, and he was sent home with antibiotics, which of course are completely ineffective against a virus.
There is in any system human frailty. The system as a system in Dallas, as I understand it, worked. The frontline healthcare person in the emergency room asked whether the patient had been to one of the Ebola areas. That was recorded, but not transmitted verbally. It was on a piece of paper or on a computer. And one of the things we've learned about complex systems is that you have to do more than type into a computer to get someone's attention or to be sure that something doesn't stay on the computer. The failure there was a direct loop from the admitting nurse to the doctor, and for the doctor not to see the checklist and go back and ask to see the patient. That was a failure of the system. That serves as a wake-up call to emergency rooms not to let a failure like that happen.
How are the CDC and state and local health departments responding to Ebola from the standpoint of allocating personnel? They all seem to have a great deal of expertise in epidemiology and in other areas that would be useful to contain potential outbreaks. So how are they employing those resources?
I think at the moment the front line in any city is likely to be emergency rooms. If people coming from areas that are currently with big outbreaks of Ebola walk into a private office in a suburb, I think the chances are very high the physician would say, we don't have the isolation facilities, we don't have the laboratory facilities. The best thing you can do is to go to the emergency room at a major hospital. Every major hospital, essentially in this country, is prepared and has the capacity to build isolation rooms. And they don't have to be fancy. They have to be isolated. They have to have a bathroom that is closed and a door that closes so that the patient can remain isolated. The communication between the city and state departments of health and CDC has gone up tremendously in the last 6 weeks. There are guidances, memoranda, data, fact sheets coming out every day. So I think people are pretty much in touch with what's happening.
About some of the smaller details, for example, contracting with cleaning services to sanitize the living quarters of an Ebola patient, or contracting with food delivery services for the benefit of people who have been quarantined. Are these arrangements likely to be set up ahead of time, or are these things that would need to be organized after an Ebola patient has been identified?
Dealing with contaminated goods would be part of the advanced planning, and I can't emphasize enough, there have been real-life rehearsals, maybe more in Boston after the Boston Marathon bombings. But people have rehearsed this with no patients, so that there's a real expectation when and if patients come, which we hope not, every hospital that sees them would be very well prepared for all of the even small details of how to take care of the circumstance. This is not a crisis that one wants to invent on the spot. This takes real thought, some experience, and preparation. And I think that's been the effort of CDC, is to get those preparations and rehearsals well under the belts of the people on the front line here.
Turning to matters overseas, the U.S. is working on new Ebola screening procedures for travelers. I wanted to ask, in your opinion, does the current screening protocol need to be tightened? And if so, what do you think they need to change?
The current screening protocol is to examine people before they get on airplanes in the 3 affected countries in West Africa to leave the country and usually go to Europe. The first thing that one has to say is that screening for this illness is an imperfect process at best. It requires conscientiousness. Every patient, every person who gets on a plane would have to be screened. They would have to be screened with these handheld temperature infrared devices that have to be calibrated. And at the moment, the healthcare systems are so weak in those countries, to be honest, one can't be 100% sure of how effective and conscientious the screening has been. In prior outbreaks, temperature screening, let's say in SARS, has not been a very efficient mechanism of picking up cases. The worry there is, as in the case in Texas, the person who gets on the plane doesn't have a fever but has infection and is in an incubation period. The possibility would be enhanced if people arriving in the States from those countries or who have been in those countries for 21 days are pulled aside after they report that, and they have to report that in immigration to enter the country, to have their temperatures checked. Everybody on a plane should be given information that has come from those countries to say, if you have fever, chills, feeling nauseous and sick, at least consider the possibility of going to an emergency room if you think you might have had any contact with a patient with Ebola. So it isn't perfect, but I think it could be made a little more intense.
Thank you very much, Professor Bloom, for an instructive discussion on this important issue. Thanks also to our viewers for tuning in to this edition of Health Watch. I'm David Morgan. See you next time.